I really felt that this morning set a really good outline of where we want to get to ensure that we deliver the type of memory assessment services that all of the people coming should be expecting. So, but I do think we have to acknowledge it is different times now. So can I move on to the next slide? So this is really what was happening with the dementia and Alzheimer's diagnosis back when we hit COVID. It absolutely plummeted, as Chloe said. Now that can't be good for the person with dementia or their carers when no one's giving them a diagnosis. I'm pleased to say the numbers are coming up, and we hope they'll come up even more. But clearly at this point, Alistair was really concerned and felt that something needed to be done because memory assessment services had actually stopped. So he convened a virtual meeting to write a short report distilling ideas and best practice, which I'll show the link to later. It wasn't focusing on diagnosis in primary care. It really was talking about the memory assessment services run by secondary care. Since that time though, and I'll talk about that in a minute, there's been further meetings, there's been webinars, and there's an acknowledgement that things are changing very fast. Next slide. So this is just repeating things, but I can just see what we were talking about in March and what we were talking about in August has really been tremendously difficult. In March, we're just starting, and now we've actually got services who have been delivering memory assessment services remotely and using digital technology. And they have learned and been able to share their learning with us, what works, what doesn't work. And I think that what's really been clear is that how we do assessments, what assessments available are constantly being developed. And so you have to keep an eye out for that because there are new things coming up. And the balance of risk may well change when we go into more local COVID spikes. How does that affect the risk about whether you see the person face to face, if that's what they really want? And it's that bit about having a blended approach. At no time is anyone saying it's all digital or it's all face to face. What we're saying is that we're going to have to use a digital approach, but it has to be based on your services and some key principles. Next slide. So these were the overarching principles. I suppose the first one started that some assessment is better than none. And it's vital that we don't lower the quality of the service provided, so that we need to make sure that we can make a diagnosis that is robust. The services need to be needs-led. I don't think that anybody would quibble about that, but I do think that some patients might not have access to particular technology, or there might be language difficulties. We need to really ensure equality of access, and I think Jeremy has been a particular advocate for this. It was also felt that the thrust of any new memory services that involved a digital way of working should not kind of avoid the risk altogether or put the risk onto the patients, but rather recognise the risk, be honest and transparent with the patients and their family about the risks, and take steps to mitigate their effect. And I think that's really important. It's about having that discussion and having that blended approach. Next slide, please. So I put some links to useful resources before I'm going on to talk about particularly the one that was put together and the first one here by Alistair. But I do want to bring to your attention the MSNAP webinars. They have got a wide range of people talking about how they're working digitally, and I particularly would like to recommend where Jeremy, and I'm not trying to embarrass him, really talks about when scans are needed and when they're not. And I think there's been a lot of concern about that, and it's very helpful having his thoughts on that from a neurology point of view. He's also, you've already got the link from Laura about remote working, and I think that is a really good paper as well. Okay, so next slide, please. So the group were really keen in, to emphasise the Sentinel role of a thorough and well-informed history in the diagnosis of dementia, rather than concentrating on over-reliance on cognitive test scores or brain scans. It's really vital. This is a diagnosis that is based on getting the history. And I think what Suzanne was saying, going back again and clarifying the history so that you can firm up the diagnosis. But it's also important there's adequate preparation, and I'll kind of talk about that a bit later, but that really has been the focus of quite a lot of services, making sure that the patient and their loved ones understand what's happening, going through, perhaps practicing with the video. A lot of admin time goes in making sure that before the actual appointment, the person themselves understand what's going to happen and is able to use the technology. And again, getting the patient's permission to phone relatives is essential. I think that what we have found, that those relatives who know an awful lot about their loved ones but have lived a long way away and haven't been able to get to appointments can now actually be engaged. So that is a good point that people have noticed with these remote assessments. I've given you a link to the IQ code, which has some is a helpful instrument of proven validity, which allows a person to detail the onset and progression of symptoms. But it is all about a thorough and well-informed history. Next slide, please. This is very busy, and I apologise for that, but this is a slide that I found useful because it outlines a test which there's an evidence base, but it also gives you some links to them. You'll see some of these are tests which you have to register with them. I'm pleased to say the mocker, they've extended the need for training, and you don't have to register for that till I think in January this 2021. But you can see the ACE is now able to be done virtually. You've got all of these other assessment tools, but there are more coming online all the time. And I think it was felt to be important that a clinician used an instrument which he or she was familiar with, while recognising the potential value in a flexible approach. We were talking to some psychologists about cognitive testing, and they said that because it was doing it in a different way, they kind of practiced with their husbands or partners and trying it out and seeing how it worked to make sure that they understood how the questions should be asked in the best way to get a response when you weren't actually sitting in the room. I mean, supplementary questions to elicit cognitive impairment for carers, or perhaps some people have said that they were sending smartphone pictures of the clock during a telephone assessment. I mean, that was another one. We've also, interestingly, people were saying that after the testing, if they'd been using pen and paper and drawing, that they've asked the people to rip it up so that they can't then use it for further testing at another time later on, which I hadn't really thought of, but I thought that was an interesting way to go forward. Next slide, please. Brain scanning. Now, whenever this comes up, people then say, well, the scanning stopped, we can't have scanning, or we must have scanning. It's a really difficult issue. And it's very difficult at the current time with COVID of having access. But I do think that Jeremy makes a very good point about whether or not the scan will make a difference to the diagnosis. If you're very certain about the diagnosis, how is it going to make a difference? And you have to weigh up the risk of having a scan, sending people to an environment potentially they could get COVID, and would it actually change your management plan? There are lots of links here, mainly to Jeremy's work about scanning, but it does help in focusing attention as to why you are doing the scan and what difference it will make. But I think a lot of people get hung up on scans, and I think we really need to think about that differently. So the another thing that keeps coming up is blood tests. And I think that it was generally felt there should be flexibility in the time between blood tests and the assessments, rather than having a standard 6-month rule. The other thing is that what has happened, because we've got more access due to COVID to the results in acute hospitals, you could often find that they've ended up having some blood tests quite recently, or indeed that they've even had brain scans on an admission, which will be reassuring. Perhaps might have had them in the last year. So it's allowed us to have access to information that, and has stopped us needing to have to do it all over again. Next slide. So peri-diagnostic and post-diagnostic support, as we've heard, these are areas that we still need to address. It's not all just about a diagnosis, it's how we can support people who have the diagnosis. So if we do need to initiate cholinesterase inhibitors, we don't necessarily have to have an ECG. People have been using their blood pressure machines that perhaps their husband has got to kind of use that to take pulses. And indeed, family members sometimes have been involved in taking pulses. So I just think we need to be a bit more flexible, and here's a link to some guidance on indications for carrying out an ECG. But if you really feel that this is a high-risk person, perhaps it might be appropriate to consider memantine, obviously if the indications, because there you might well have a renal function result. So but it's not all about drugs, is it? It's about making sure that we address any other treatment options, so perhaps addressing any depression or anxiety, reviewing the anticholinergic burden, all of which will impact on their functioning. And the cognitive stimulation therapy is now being delivered by Zoom, and there's kind of evidence coming together that that is actually working. So again, the more we know about and we developed our ways of delivering these treatments and support virtually, the more we can learn what works and doesn't. So there are singing groups, there's obviously the Dementia Advisor Service with telephone or video appointments, and then there are volunteer schemes as well. And again, that's what COVID has had an impact on. There are more schemes and support available than there perhaps were before, and this is a chance to really link into those. I'm not saying it's all perfect, but I just think that when one's thinking about delivering services in a remote or a digital manner, that there are all these other options. And then the START that was mentioned earlier can be delivered by telephone or video consultation. So we can still offer support to carers. And I think that's really important. Next slide. So technology and confidentiality, again, another area of great concern for people. And I think that, you know, the slide really speaks to it for itself. But I do think that in certain groups, perhaps when somebody's living in a household, an old person is living in the household with lots of other people, and it's quite difficult to necessarily get a private place to have these discussions, and they need a bit more preparation than if you've got interpreters. I had Ben Underwood was telling me about a call he got about somebody with hearing, it was severe deafness, and how he must have a face-to-face, couldn't possibly have a remote. But as Ben said to the GP, well, if he comes to a face-to-face, I'm going to be having a mask on, so he won't be able to see my mouth move, and he won't be able to kind of interpret what I'm saying. So actually, a video will potentially be better, and in fact, it will work very well with a video. But there are things about security, and we also need to think as health professionals that we need to remember that we need to be in a private place, not people interrupting. And, you know, I know that sounds obvious, but unbelievably, I was listening to people talking about mental health tribunals and how somebody went to answer the door for an Amazon arrival. So I think, you know, it's easy when you're working perhaps from home or from an out to just not see that it needs to be a very private place for this work. Next slide. So research, I think that did come up in that presentation, thinking about the fact that we still need to do some research. We still need to look at people with dementia and come up with solutions that work for them. And my colleague Ben Underwood said that research is possible via remote methods. I am not a researcher, but I, you know, have to accept that's what he said. But I do think it's important when one's talking about moving and using memory assessment service in a remote way, that we don't forget about the need to offer the chance for people to become involved in research and to support it. Next slide, please. So the most important thing is, and what this is all about is, are we delivering a service remotely that is actually what the person with dementia and their carers want? So I'm going to give you some feedback, not all positive, but a lot is. First of all, I'm going to quote Ben Underwood's feedback. So this is just generally about the first bit about virtual consultations, that generally the doctors felt it was 4 out of 5, and their view of the patient's experience was 4 out of 5. Well, that, you know, maybe I think a lot of us have experienced virtual consultations and they have worked. Having said that, we now need to get down onto older people's mental health services, and they're, well, 3.9 out of 5 is okay, but it's only clinicians marking. So really we need to hear from patients. And actually here they were asked whether they would consider having a remote assessment, and 82% said yes. I think we just mustn't make assumptions that everybody will say no. Some people have really benefited, said that enjoyed it because they didn't have to queue up to try and get into the car park, and it was quicker, and it was less stressful, and their family members could be there. But, you know, it's not all good. The Alzheimer's Society got feedback from members, and they were in particular concerned about the worry about the quality of assessment. And I think that, you know, that was one of our first things. We must ensure that we are giving a high quality assessment with a diagnosis they can rely on. I think there was other concerns about the fact they couldn't access the technology. And I thought this one was particularly relevant in that some of the people who are feeding back, so these are people phoning up the Alzheimer's helpline and who have had contact with memory assessment services, and they were saying about the lack of choice. And I think right at the beginning we talked about how it had to be blended. We've had people saying they prefer video, and other ones have said they prefer phone, but everybody's got their own particular preference. What they have said is things that would have helped is clarity of waiting times, and I really think that's important. my mother had a video of the pharmacist, and she was told it was going to be between 12 and 6. Well, she's waiting by the phone from 12 to 6. That's very stressful. I really think we need to make sure that we're clear about the waiting times. I'm sure you all are. This feedback suggested they wanted video over phone, and they wanted support. So that whole bit about the admin going through, checking with them that they know what to expect, how it's going to happen, how that they can use whatever video technology they're using. So I think that's quite interesting. I mean, there were some terrible stories of somebody being told to give, a carer being told to give the diagnosis to the person with dementia. Well, I mean, none of us would be saying that that was a good thing to do. So, you know, I think that there are some bad practices, and we need to ensure that we actually give the diagnosis in a way that is the best for the actual patient and their carers if they want that. So then there was another feedback on Zoom. I mean, obviously it's not to do with memory assessment services, but the feedback from this I think was really helpful as well, about the importance of preparation and information, again choice, the quality, sharing the links and summarising the next steps. So I think it's all about information and being clear what's going to happen. And I thought the very last one, not asking people to provide information you've already have access to. I think we all acknowledge that being on any form of digital platform is exhausting. And so we do need to not make that unnecessarily long by asking them what we've already had access to, information we've already had access to. So, you know, there are some negatives from people, but there are also some positives. And I think that not having a diagnosis is much worse, and we need to ensure that our services can deliver memory assessments in the time of COVID, because it doesn't appear to be going away quickly. Next slide. So I've got some time for any questions. And as I said, my apologies that Alistair's not here, and I'll try and answer them if I possibly can.
Thank you very much, Amanda. That was really fascinating and detailed. There's a lot of comments coming into chat